I'm going to start with Len Rubenstein. Len has been my mentor for more than 15 years, um, is a professor at Johns Hopkins, and has written the book Perilous Medicine. He also founded the Safeguarding Health and Conflict Coalition, I think about 15 years ago, and has really been leading the charge on protecting health and conflict for far more than that time. Len, do you want to get us started?
Thank you, Rohini, and welcome to everybody attending today. The Safeguarding Health and Conflict Coalition, as Rohini said, was created about 14 years ago. And the reason was that we knew that combatants frequently attacked healthcare in war, but the international community had basically ignored the problem. It had passed no resolutions setting out a framework for action. It had not promoted accountability or even prevention measures. The World Health Organization did not collect data on the attacks. There were no concerted UN efforts to put the issue on the international agenda. The media paid little attention. And most importantly, perpetrators enjoyed complete impunity for their acts. Since then, the coalition and its members, along with colleague organizations and leadership by some UN agencies, has reported annually on the violence, and you'll hear more about that report for 2024 today. We've raised the alarm about the crisis of violence against healthcare and conflict. And in this period, we persuaded, along with others, governments that they had to squarely address the problem. The World Health Organization is collecting data on attacks, though the system remains inadequate and non-transparent. The UN Security Council adopted a resolution 2286 in 2016 laying out actions states need to take. And the media started paying attention. And yet what we all know, what you will hear about today, is that these actions have been mostly performative. There remains no serious global commitment to stopping the violence or the arrests of hundreds of health workers every year. There still is complete impunity for the attacks, as accountability mechanisms which are available, including criminal prosecutions, have not been invoked. States have ignored commitments they made in Resolution 2286. Worse still, the number of attacks each year continues to rise. And new technologies, as you also will hear about today, like drones, have made it easier to attack healthcare. And today, we see something new, efforts by states to undermine the stringent special protections healthcare enjoys under international humanitarian law. They instead promote interpretations that seek to dilute their obligations, and in the words of the International Committee of the Red Cross, giving themselves more leeway to kill. The coalition will not stand by in the face of this. We need to continue to present the facts, demand accountability, and do more ourselves and with our friends and colleagues to ensure greater mobilization of civil society and the health professions to demand action. I ask everyone participating today to join this effort and look forward to the discussion we'll have today. Thanks.
Thank you, Len. Christina, I think we're going to have you speak next. Christina Wille is coming to us from Geneva. She's the founding director of Insecurity Insight, which was founded in 2008 in the context of helping the ICRC actually with its first attacks on healthcare work, which became a 16-country case study and the foundation for their Health in Danger project. Since 2016, Insecurity Insight has supported SHCC to promote transparency around publicly available information on attacks on healthcare. And now I would say their weekly and biweekly fact sheets on countries all over the world have become the go-to source on attacks on healthcare, as well as on humanitarian workers around the world. And all their data is public, which is pretty laudable. Christina?
Thank you, Rohini, and welcome to everyone, and thank you for being here. I will try to share a presentation because I find that the data I'm going to talk about is much easier understood if we can also look at some of the graphics. But the many of the findings that you will hear within this presentation very much are around the issues that Len has already mentioned. So I think the way to think about this is when I'm presenting this data, it is the evidence-based around which we center these messages that Len pronounced and that we also will get to later. So as Rohini already said, last year has been one of the most troubling years. Never before have we documented as many incidents on violence against healthcare than in that particular year. And we are aware that this is not the full number. Many incidents go unreported. But what is so particularly troubling is just how much this is an increase over past years. 15% to the previous year and a staggering 62 compared to 2022. And the issue that sort of upsets me perhaps, I'm trying to move this presentation and now it's no longer moving. So I apologize for this. I think this sometimes happens. So I'll start the sharing again, and I might have to just keep it on this sort of really slightly weird thing that you can see the next slides. I don't know what it is. It sometimes sort of blocks the computer. So what I find particularly troubling is the number of health workers who were killed last year. And again, this is not the total number. This is the number we've been able to record. And the rise compared to previous year is just frightening. Another issue that is very concerning is the number of health workers who are arrested. And while the numbers in 24 were not quite as high as the recorded numbers of 21, we do know that this is an ongoing issue that is particularly underreported. And it is very troubling because it obviously affects the individuals, their family, but it also really undermines the way the health systems can work. The kidnapping, by contrast, is an issue where we've seen a fall in numbers. But we always have to be a little bit careful in how we interpret this data, because lower numbers of one particular type of incident does not necessarily mean that something is getting better. And that is sort of perhaps illustrated when we look at the Democratic Republic of the Congo, where the number have fallen particularly noticeably in terms of the kidnappings. But I'm concerned that what we are seeing here in terms of the fall of the numbers of kidnappings is equally a reflection in the reduced presence of health workers in a country that in its east has seen increasing violence and increasingly more difficulties for health workers to actually provide their care. And that's then also something that can be reflected in particular other numbers of harm we're seeing happening to health workers. But one of the most important issues is also one that I think Len already mentioned in his opening remarks. And this is that it is states that are driving this particular violence at the moment. While until 2020, it was still more incidents attributed to non-state actors, it has since then been that it is the states that are driving it. And in the wake of this dramatic increase of violence seen here in red, it is also that the non-state actors have increased their violence against healthcare. So we've seen a very troubling overall rise. The other element that is linked to the violence, in particular as we've witnessed it last year, is and also an issue that Len has already alluded to. It is the change in the weapon systems used. Since 2022, we've seen a massive increase in the use of explosive weapons affecting the health system. And as we can also see on these bubbles on the side, it started in Ukraine. And in 2022, it was essentially a phenomenon we saw in Ukraine. And since then, it has spread to more and more countries, causing enormous devastation to the health system. And with this graph, which can be a little bit complicated when you look first at it, we also want to highlight that within these explosive weapons, there are also sort of different weapon systems used. And one striking factor is what you can see in orange, and that is the increasing use of drones. So this is something that we've definitely noticed over the past few years, and that is increasingly affecting the health sector. But so continue to be airstrikes, bombs dropped by planes, or ground-launched explosives. The IEDs, by contrast, are really relatively little in percentage terms at the moment. So this just highlights how the violence fluctuates in its particular form, but it continues obviously to be extremely devastating for the health sector, whatever the particular weapon type. So one of the big questions really is of how do we think about this problem and how can we address it? And this is a concept that was developed by Robin Copeland within the ICRC, saying there's essentially three key elements. It is the potency of the conflict party. It is what weapons do they have? What can they do? How can they attack the health sector? It is also what do they want to do? Is it their intention to do it? And then there comes this whole issue that Len also mentioned. What sort of legal frameworks do we have to address the way weapons are used and the way the health system is affected? It is around IHL, the distinction, the proportionality, and the precaution, and then what do we do to implement that? But at the very top, we've also put here the vulnerability of the health system, because it is also how individuals are exposed, because there may be paramedics or because they're working right at the front line, that affects how vulnerable individuals within the health systems are. And then there is also the question of how resilient a system can be, how much support it gets to keep going despite this destructive violence. And so there's many ways in which we can think and have to think about it in terms of protecting the health service. And to help this one particular aspect, to reduce the vulnerability of the health system, there is also now a handbook that discusses 4 particular areas of how we can increase the awareness, improve preparedness, the response to when something happened, and how can we develop a sustainable, resilient health system. And this handbook is available in 4 different languages. But this is obviously this one part of addressing the vulnerability, but these other 2 parts remain equally important, and we will return to those during the webinar. One other element that has been very noticeable in 2024 has been the role that social media has played in undermining trust in the health system, and the way communication on social media is calling into question the whole medical ethics of neutrality and providing care on the basis of need, and bringing out accusations of being an accomplice of terrorism or other acts by simply providing care to all those who need it. And the impact of all of this violence is obviously on the individual health worker, and how difficult it is to work under such circumstances, to see colleagues suffer, to see their own families suffer. And then there is the impact it has on the access to healthcare for patients, and how much harder it gets to reach healthcare. And there's also evidence that individuals may delay seeking healthcare because it seems so dangerous to even go there and seek care. So to address all of these things, there are these 3 key recommendations that the Safeguarding Health in Conflict Coalition puts forward. It is, as Len says, it is ending impunity. It is really looking at how these conflict parties conduct their warfare and what we can do to ensure that the laws of war are actually adhered to. But there's also elements we can do to strengthen prevention. And very importantly, we really need more global and domestic leadership on these issues. And for that, I really thank everyone who is here today for your contribution in addressing this important issue and for your leadership in bringing this issue to the attention of all the people who really need to change how we conduct responses, awareness, and reactions to these events. Because really, we're here in this webinar today to support the health workers of Sudan who took to the streets and have been demanding change to how things happen and paid heavy prices. It is for the health workers of Myanmar who really want our support in very, very difficult circumstances. And the health workers of Gaza who are working under possibly the most difficult circumstances we can imagine there. And with that, I really thank you for being here, and I hope you will take a lot with you from the contributions of those who've been to many of these front lines. Thank you.
Thanks, Christina. And in addition to that QR code in the webinar chat, you'll see links to the report as well as a lot of the data as well. And I'd encourage you to ask any questions in the chat, and we'll try to get to a few of them after the panel and then in the discussion. I'll just start with one for you, Christina. We have a minute. I think it was Les Roberts wrote that his colleagues in DRC were saying that the compounding of funding cuts from USAID and the violence was closing almost all the health facilities in the Kivus. And I wanted to ask you about that sort of compounding issue of humanitarian cuts and growing violence. And as you said, different types of violence kind of expanding.
No, thank you for bringing this up. I think this sort of really underlines how many complex issues come together. So the impact of the USAID cuts, this is something we'll probably see largely in the 2025 data, but this will possibly also to lead to situations where there will be fewer recorded attacks on healthcare, not because there are less intention to do it, but because the availability of healthcare is so much reduced. But the other element to think around of what the impact of the USAID cuts is also a very toxic discussion around all of this on social media. And it is really frightening to see how many people are framing it and lauding it and applauding it with an idea that it is an interference into the sovereignty of people to receive such support for healthcare. And I find these such upsetting comments because I am sure they're not written by those who are in need of this care, but they come from people who also sort of drive an agenda that is then also making the life of health workers even more unsafe in these circumstances. So yeah, thank you for this really important question, and we have a particular assessment of for the DRC of how the discussions around the USAID cut fundings played out there.
Thanks, Christina. And yes, please ask questions in the Q&A, or you could put your comments in the chat as well. In the meantime, we'll start with Robel. Robel Alemu is a PhD student at the University of Toronto, and he serves as the Director of Communications and Senior Analyst at the Amhara Association of America. AAA is a US-based organization that documents conflict, violence, and political repression in Ethiopia. It works to educate policymakers, journalists, academics, and other stakeholders about human rights trends and pressure leaders to promote justice and accountability. Robel, I was wondering if you could share some insights from your work documenting this sort of violence in Ethiopia.
Certainly. Thank you for the introduction, Rohini. First and foremost, I want to thank the Safeguarding Health and Conflict Coalition for their great work in organizing this important platform. Our organization documents conflict, violence, and political repression, as Rohini mentioned, and we employ a team of human rights investigators based in Ethiopia. So they collect firsthand reports and data, which we process abroad and incorporate into daily updates, weekly reports, and annual thematic reports, which are made available on our website. So today I want to speak to you a little bit about the impact of conflict on healthcare in Ethiopia's Amhara region, starting with a little bit of context on the war. But in recent years, generally, Ethiopia has experienced a rise in conflict and violence involving state and non-state actors in various parts of the country. This rise has led to a disproportionate impact on the regional healthcare system, impacting health workers, patients, medical facilities, health supplies, humanitarian activities, and much more. The Amhara region in particular has been impacted by 2 consecutive major wars and sporadic outbreaks of violence, which have led to significant casualties, mass property loss, and mass displacements from both urban and rural parts of the region. Between November 2020 and November 2022, the war in northern Ethiopia devastated millions across 3 regions, namely Amhara, Afar, and Tigray. Particularly in 2021 and 2022, militants associated with the Tigray People's Liberation Front and Oromo Liberation Army invaded the Amhara and Afar regions and carried out a wave of violence and property destruction, including industrial-scale looting of hospitals and clinics. In November 2020, the Abiy Ahmed-led Oromo Prosperity Party regime and the TPLF signed a peace deal, but this deal excluded Amhara representatives, and then war later reignited in the Amhara region months later at the end of April 2023. And by August of the same year, Abiy declared a state of emergency, which was later extended in early 2024. So the Amhara war involves state forces under Prime Minister Abiy and his Oromo Prosperity Party regime on one side, and the Amhara Fano Defense Force on the other. And today, as the war in Amhara enters its 3rd year, the region continues to suffer with no clear end in sight. But since the start of the war, AAA has reported a pattern of atrocities with hallmarks of genocide, war crimes, and crimes against humanity by the state forces under the Abiy regime. Specifically, the regime's armed forces have carried out hundreds of civilian massacres, weaponized sexual violence, mass arbitrary arrests in concentration camps, routine attacks on public and private property, communications blackouts, closures of water, electricity, and banking services, and overall a strategy of collective punishment to inflict maximal suffering on the civilian population, including destruction of food supplies, travel restrictions, which have hindered passage of critical supplies. And so the Amhara war has been characterized by its asymmetric nature, with the Abiy regime utilizing drones, airstrikes, and heavy artillery weapons, which have disproportionately targeted civilians. AAA has recorded over almost 200 drone and airstrikes, resulting in more than 1,400 civilian casualties. The regime has purchased weapons, secured financial support, and signed MOUs with the UAE, Iran, Turkey, Russia, Azerbaijan, and has received billions in financial support from the IMF and World Bank, as well as agreements with the United States, Canada, and numerous other countries. So this is just a brief contextual framing of the axis of support behind the Abiy regime and the toll on the Amhara population. But over the course of the war, AAA and other human rights organizations have documented widespread attacks on health workers, medical facilities, patients, medical supplies, and more. And last year, for example, Human Rights Watch released a 66-page report on attacks on medical care in Amhara region. They specifically referred to the army's attacks as war crimes, clarifying that civilians have bore the brunt of the war and urged for international actors to promote accountability. The report mentioned the army and allied militants carrying out attacks on medical care in more than a dozen towns, noting attacks on doctors, patients, medical transports, and looting and destruction of medical facilities, including through the use of drones and other explosives. Last year, the Forum for Higher Education Institutions in Amhara region also addressed the health crisis, noting several trends, starting with existing damage to the regional health system from the Northern War, when damages were inflicted on over 40 hospitals and 443 health centers across the 3 regions, with a large proportion of that being in Amhara, and noting that only 5% of damaged health centers had been restored in Amhara. So this is another trend. And then in addition to that, there was a drastic increase in the rate of mental illness within the region due to a number of factors. The forum also noted more than 5,000 survivors of sexual and gender-based violence who sought healthcare in Amhara in the year leading up to September 2024. And lastly, the forum called for international support in aid delivery, including food and medical supplies, and support for long-term peace and recovery efforts. Tripoli, on its part, has recorded 27 specific incidences of attacks on healthcare across 24 districts in the Amhara region, and these have involved killings, physical assaults, arbitrary arrests, and abductions of health workers and patients, and destruction of health clinics, with the use of fatal drone strikes in several districts such as Lasta, South HFR, South Mecha, and Delanta. Tripoli has also noted numerous concerning trends, but in the best interest of time, I'll only mention a few. Travel restrictions, road closures, and arbitrary tolls, preventing rural communities from accessing primary care centers, repurposing of emergency transport vehicles for military use, leaving no means of transportation for emergency patients and expecting mothers, looting of hospitals and health clinics across the region, cutting off the public from access to medical facilities, which are sometimes used exclusively for wounded soldiers. And these patterns have resulted in a number of important health outcomes, concerning health outcomes, many of which are not currently being formally tracked at a regional level. And these include rising incidence rates of numerous diseases, including recently monkeypox, cholera, malaria, TB, HIV, and more. In addition, infant immunization rates have fallen below 60%. Maternal and infant mortality rates are on the rise. Access to healthcare is declining. There are shortages of medicines and other supplies, and a critical lack of support for IDPs in various shelters in the country. And as I say all of this, just a very important caveat. Since last month, there's been a nationwide health worker strike with medical doctors, nurses, and others in the healthcare industry calling for improved wages and health system reforms to enhance the country's healthcare system. In response to this appeal, the state has launched a hostile campaign, which has seen dozens and possibly hundreds of health workers arrested across the country. So from the capital city of Addis Ababa to Amhara region and Oromia region as well. This has led to complete shutdowns of hospital wards across the country and reduced access to healthcare for millions of patients. Unfortunately, the Ministry of Health responded with dismissal and an endorsement of the state's military response, further exacerbating the crisis. And so experts report this response will only serve to further alienate health workers, contributing to the departure of high-skilled experts, leaving significant medical gaps in services within the country. And so this is a developing issue which is undermining the already fragile health system in Ethiopia. And to wrap up, in this overview, I've highlighted some of the trends we have noted from our monitoring activities and those of other organizations, which we hope will enlighten fellow advocates on the realities of the Amhara war and the situation throughout the country. And to this end, we believe the international community can play an important role in this process by giving due attention to one of the world's deadliest wars, suspending military and financial support to the Abiy regime, and utilizing all available tools to pressure the regime to cease its hostilities in the Amhara region, restore access to basic utilities and communications, provide unfettered access for humanitarian organizations, and importantly, to stop all targeting and persecution of civilians, including health workers. Thank you.
Thank you. A couple questions came through in the chat, some of them that I think we should save to the end, because all of us should answer them. But I'll start with Raphael Vandenberg asked, in addition to the above points on risk management and security strategies and preparedness and protection, what can you recommend as good practices concerning MHPSS and especially for local staff? What do you at AAA do for the local staff anyway?
So AAA's support is limited to documentation of the human rights violations with very limited resources, but at times we have collaborated with other civic organizations to provide humanitarian support. So for example, during the war between 2021 and 2022, we collaborated with dozens of other organizations to provide aid to IDPs. There was a very large displacement crisis, and that involved hiring a group of medical experts to be deployed to these camps and directly provide care to some of these affected communities, which were survivors of violence throughout the country. But with that being said, it's very difficult, especially given that our reporting oftentimes implicates the state, as my presentation outlined, and that sometimes creates a little bit of friction and tension where there is a desire for us not to be involved. And so our work is done with a very high degree of sensitivity, with consideration for the security of the people that we collaborate with on the ground. But with that being said, we're actively looking for sources, especially for some of the data that I shared earlier, which is sometimes also deliberately withheld from the public. And it's on very rare occasions that actually we see an opportunity for some of this data to come to the forefront. So I think there needs to be a very enhanced consideration given to what's going on, as well as increased resources. As we had heard earlier in this webinar, there was the closure of the USAID, which services, or cutting of the funding, which has drastically impacted healthcare not only in Amhara region, but also surrounding parts of the country. And so with this declining funding and ongoing insecurity, there is a very major impact. And I think our data is actually only showing the tip of the iceberg. So the issue is expected to be much more severe than it already is. But if there are any groups that are interested to help, we invite them to reach out to us, and we can definitely explore further areas for collaboration. Thank you.
Thank you so much, Robel. I'll introduce Dr. Tammy Abou-Ghanem. Like me, she's a fellow board-certified emergency medicine physician based in Chicago. She completed training at Advocates Christ Medical Center in Chicago, where she focused on the intersection of social justice and medicine and the use of ultrasound in resource-limited settings. She has been to Gaza since October 2023 3 times. And I think one of them was just at the end of the ceasefire as well. And so has had a broad range of experience working in Gaza during the different sort of political situations there. And she's been there with Med Global and as well as with Medical Aid for Palestinians. Tammy, do you want to get started?
Sure. Thank you so much. So yeah, just to start, a little bit of background on my work in Gaza. As Rohini mentioned, I am an emergency physician, so all of my work is clinical in nature. I first traveled to Gaza in March 2024 with the WHO as part of their emergency medical team structure. Initially for 2 weeks, and worked in the emergency department almost exclusively, with some stints in the ICU. So I also returned there after the closure of Rafah in the summer of 2024, and then most recently in March of 2025, where we witnessed the breakdown of the ceasefire. So got about 10 days of ceasefire in there before everything broke out again. So as you mentioned, Rohini, as a result, I've witnessed and worked in the healthcare system in Gaza in a variety of ways in different contexts. And so able to comment on the ways in which it's been affected, not only by direct attacks, but also by the restrictions that Israel has implemented over the last 20 months, which to my mind constitutes attacks and violence against healthcare. So as mentioned in the SHCC report pretty comprehensively, the healthcare sector in Gaza has been targeted pretty heavily by the Israeli military in both attacks on infrastructure and personnel. And unless you're paying very close attention to work in this sector, you're largely unaware of the role that these Israeli restrictions have played on the ability of the healthcare sector to both recover and continue to deliver services to patients and IDPs. So in brief, Israel controls land, air, and sea access to Gaza and has used this access to set certain restrictions for humanitarian aid entering the Strip. So in the winter of 2023, UN OCHA, the Office of the Coordination of Humanitarian Affairs, was able to send in relief personnel through the Rafah crossing in Egypt with certain restrictions. So Israel stipulated that certain materials were not allowed to be carried in by personnel and aid trucks. And for many, many years, they've had a designated dual use item list in which they list out items that cannot enter Gaza without going through sort of a rigorous prior authorization process. Previously, it had items like concrete slabs and construction materials, as well as quantities of certain chemicals. But as it pertains to the healthcare sector, it also includes things like oxygenators, generator parts, replacement parts for CT and MRI machines. I have colleagues that years ago attempted to bring in oxygen tubing, like nasal cannulas and non-rebreathers, in through the Erez crossing in the north of Gaza, just pre-2023, and those items were denied, confiscated and denied. So in the first few months of the genocide, this list was expanded to include things like medications and medical equipment. So the first time that I traveled to Gaza in March of 2024, medications like morphine, fentanyl were on the dual-use item list. And so medical personnel were forbidden from bringing those in. The central issue is that there's no real physical copy of this list. And so NGOs and healthcare workers that traveled into Gaza had to submit an itemized list of supplies each volunteer was bringing in, which would then be sent to basically the military liaison to the WHO called COGAT. And this is problematic for other reasons that we can get into later, the absence of a physical list to reference and to possibly appeal. So interestingly, NGOs that were soliciting volunteers to accompany them in Gaza and carry out a variety of healthcare roles, these NGOs did, whether purposely or inadvertently, play a role in legitimizing these restrictions and adherence to them. So we all know it's the height of absurdity to consider a medicinal painkiller a dual-use item, as you really cannot. It's very difficult, at least to my mind, to weaponize things like morphine, Tylenol, and ibuprofen. And so acknowledging this arbitrary rule and acting upon it and notifying your volunteers that they will be subject to it, it's kind of the classical conundrum of humanitarian access versus ethics. Do you comply with an arbitrary and unethical rule in the hopes that you can do more good through the access that it buys you? So dozens of NGOs became complicit in this structure to such a degree that some began searching the bags of their volunteers and cautioning them not to talk publicly about these restrictions for fear of being stripped of their status and their access. As a point of comparison, crossing through the Rafah Egyptian border, Egyptian authorities did subject volunteers to searches. We were not restricted in terms of the number of bags that we could bring in. So my team of 8 at the time, various specialties in medicine, carried 42 bags into Gaza in March of 2024. And of course, for a system that's been deprived of anesthetics and painkillers and all of that, it was really a drop in the bucket. And we found that our supplies were used up pretty quickly. What this meant realistically, these restrictions working on the ground. I worked in the middle area of Gaza at a hospital called Shuhada al-Aqsa. And every single day we had mass casualties as a result of Israeli airstrikes on nearby buildings. All of the tourniquets that we bought were used up by the end of my very first day. And as a result, we began using other supplies. And so the healthcare workers of Gaza, bless them, have had to improvise a lot. So we use double and triple tied Foley catheters, essentially giant rubber bands, as tourniquets in attempts to stem bleeding. And we were delaying surgery because of the absence of sterile equipment and also OR time. So more significantly, we also had very few ventilators. Israel at the time did not allow a sufficient quantity into the Gaza Strip. And so there were 2 ventilators that we used in the emergency department and a few more in the intensive care unit, which as a result of the mass casualties were almost always full. So this meant that the level of triage intensified to a degree that was causing severe moral distress for the healthcare workers of Gaza and for the volunteers. It meant that we had to choose which patients we could maybe save with a ventilator, and sometimes which patients to remove from the ventilator. And this choice was especially painful during shifts where the vast majority of the victims of Israeli airstrikes were in fact children. Fast forwarding to when I returned to Gaza 4 months later, the Rafah border was closed and occupied by Israeli military forces, and the only entry granted to the WHO personnel was through Jordan, through the Allenby Bridge crossing into the occupied West Bank, and then taking a 3 to 4 hour bus ride across Israel through the to the Kerem Abu Salim crossing, which is in the south of Gaza. Because we were now passing through Israel, there was a whole new set of restrictions that was imposed. So we received word from the WHO through COGAT that each person was allowed to bring only one bag. So one airport size 23 kilogram bag. No more than 2 phones, 1 laptop, and 1 power bank. And anything that we brought was supposed to be for personal use only. Again, the dual use item list applied, but this was a much more stringent form of these restrictions. Anything that was scanned at the border at Allenby that was felt to be medical equipment or non-personal would be confiscated, and the entire convoy would be refused entry that day. And this did happen multiple times at the Allenby crossing. So having created this kind of culture of fear and brand new wave of restrictions among the NGO coordinators, we found that the reality depended day to day. So the people searching our bags at the Allenby crossing oftentimes had no idea what constituted medical equipment and what didn't. And so there was a lot of confusion about this. Some volunteers took the risk, myself included, and we brought in ultrasound devices and surgical equipment that we thought kind of looked like they could be personal use items. I personally brought in a few dozen more tourniquets, and my ER colleagues in particular were telling me that Israel had restricted soap and antiseptic equipment in the months leading up to my second rotation, to such a degree that Gazans started to begin to manufacture their own soap. The hospitals were washing everything with a mixture of salt water and iodine. That was essentially the only sterilization that was available in the emergency department that summer. And we were warned specifically that alcohol-based gels and sanitizers were not allowed. So we resorted to doing things like packing in dehydrated soap sheets that were very lightweight and could pass as personal use. And we reconstituted them in the hospital for general use. And quite frankly, many times that was the only cleansing agent that was available to us. Otherwise, we were washing our hands with soap and iodine. So the OCHA and WHO dashboard at this time was showing that only 1.4% of disinfectants designated for entry ultimately ended up in Gaza that month. There was no explanation given for this. Again, sets of arbitrary restrictions on healthcare that slowly started to strangulate the healthcare system. And this showed up in macro and micro levels. So at the micro level, this meant that nothing was ever truly sterile. And one of our surgeons went on a hunt one day and found literally the last 30 sterile drapes in the south of Gaza in one of the Ministry of Health warehouses, which is hardly enough for one afternoon if you were lucky enough to not get a mass casualty. And of course, we were never that lucky. So post-op infection rates soared, flies were everywhere. And at one point we had staff whose main function was to suction maggots out of the mouths of ICU patients who were intubated almost every morning. So these are details that really escape the headlines, although all of this information is mostly publicly available about the restrictions, and I can link in the chat the WHO and the OCHA dashboards where you can play around with the data and kind of see what these restrictions have meant on a very kind of micro level. But it is an attack on healthcare, to my mind, that is insidious, but also just as violent in terms of the trauma that it creates for healthcare workers and for their patients, who deserve a basic minimum standard of care, but they are not able to get it because Israel has essentially manufactured the scarcity in an attempt to strangulate the healthcare system. So when we discuss protection of healthcare and its personnel, I think we have to expand our understanding of that and grant extension of these protective mechanisms to supplies and logistics and resources that make the work of healthcare possible. I'll stop there, Rohini, and if we have a couple of questions, we can feel free.
I don't even know where to start with the questions, Tammy, for you. I will say, I guess I have a more clinical question for you. This lack of soap and the ventilators, just one thing we study is the impact of attacks on healthcare. And I was wondering if you could spend a moment talking about infection. What you described sounds like something from a movie about the Civil War with no soap.
Correct. Yeah. The healthcare workers of Gaza have had to find ways around the scarcity naturally. So, but that doesn't mean that they are always successful, right? Despite their best attempts. When you are unable to sterilize surgical equipment, especially in mass casualty and trauma situations, you sort of do the best you can in terms of damage control surgery. So somebody that's requiring an amputation really cannot wait very long before tissue starts to rot on the body. And so you have to amputate that tissue, wrap it up as best you can, and go from there. In the beginning, in I want to say November and December of 2023, many of our surgical colleagues began washing out wounds with things like vinegar, in addition to salt and brackish water, in an attempt, and you're right, it sounds like Civil War era medicine, right? Like World War I era medicine. Naturally we see things like post-operative infection rates. At one point in my hospital, almost every single person that was operated on developed a post-operative infection. This is not just complicated because you now need antibiotics to fight this post-operative infection, but you also need to return to surgery to remove the infected tissue. And so you get repeat cycles of amputations that become more and more severe, but also you are compounding these infections. And so healing is excessively difficult when you do that. So obviously this has an impact on both, the time and resources it takes to care for these patients who should have been just like a one-stop surgery, post-op recovery, and you're now seeing these repeat cycles of folks experiencing complications as a result of these restrictions.
And I'll add that with the limitations and the restrictions on food and things, I think malnutrition probably compounds infection and healing problems as well, right?
Definitely. So the restrictions on food, which I didn't touch on very much, but it's intimately linked to the ability of patients to recover, right? Not only the stamina of the healthcare workers operating on them, but also protein calorie malnutrition plays a role in immunity. And if you are malnourished, you are not able to mount a sufficient immune response to these infections. And so you have a population that is now at baseline malnourished. At 1.96% of Gazans were reporting food insecurity, according to the World Food Program. So you have a baseline population that is malnourished, and you add on top of that traumatic injury and infection, and the immune system is not able to mount a sufficient response. And so you're seeing increasing morbidity and mortality that is not reflected in the numbers that are coming out of Gaza and in the Ministry of Health.
Thank you so much, Tammy. We were planning on having a colleague from Sudan speak, but as is common in conflict, I don't think he's able to connect. I'm going to share a short video from a documentary film about health workers in Myanmar called Frontline Hospital. Just give me a second to sort this out.
Rohini, it seems like most folks were not able to get audio for that. I don't know if that's the case for.
It always happens.
Yeah.
I'm going to send it to the link for you. I'm sorry if you weren't able to hear the audio. Whoopsies. Thank you. Okay, I put the link in there if you didn't get a chance to listen. But Joe, I was wondering if you could close us out. Joe Amen is the new director of the Center for Health and Human Rights at Johns Hopkins Bloomberg School of Public Health. And as I mentioned, he and I will be stepping into big shoes as co-chairs of the SHCC.
Thanks, Rohini. And thank you, all of my fellow panelists. It's been a really important and difficult discussion so far. And also thanks to the participants or the people attending. I wanted to come back to what Christina identified as sort of the three key recommendations from the SHCC report, which were ending impunity, strengthening prevention, and strengthening global and domestic leadership. All of these are things that we have been doing continuously since the beginning of the coalition's work. And in every case, we're not where we want to be in terms of seeing the impact, seeing the leadership, seeing the prevention of attacks. And so, just a reminder of kind of where we are. There were 927 health worker deaths in 2024, 473 workers arrested. This is a big increase. There are other actors who are engaging in the space, WHO, the High Commissioner for Human Rights. There are needs for more actors to be engaging in this. And it was mentioned in the comments that we're coming up to the 10th anniversary of UN Resolution 2286, which required the Security Council to track attacks. And I think that's an opportunity to try and continue to do what we have been doing, which is draw attention to this issue, which is track it, to better understand it, to explain it. If we're going to prevent attacks and prevent the impact of attacks, we need countries to commit to doing proper education of military forces and improvements to their terms of engagement in war. We need global leaders to really say that they recognize that this is an issue that devastates countries' healthcare infrastructures for decades following these attacks. We need to also see the application of international humanitarian law so that there's consequences for the forces that are attacking health systems and attacking health workers. None of this is easy, and I wish that the report would, be read in every capital with every military and militant force to expand the impact that we can have. But I am encouraged by the number of people that are on this call, listening to this, and will take it into the different spaces that we're not able to reach. But there's no magic formula for achieving success in this, and it's both a sad fact that the coalition has been around putting out these reports for so long, but also a testament to the commitment and dedication of everyone that's been involved in this so far. So I'll end with that, but obviously it's not an ending. It's the end of this discussion, but the beginning of hopefully more partnerships, hopefully more collaboration, hopefully more advocacy efforts in capitals globally. Thank you.
Thanks, Joe. And I agree. Let's just jump into some of the questions that were already asked in the chat. And then I welcome all of the participants to add more as we go on. There's some hard-hitting ones. So Len, Christina, Tammy, Robel, Joe, any of you can answer these. Kaveh Kushnood asks, how should we respond when perpetrators justify attacks on healthcare facilities by citing military necessity? And I would also add, Len, often by citing that that the facilities are, hosting perpetrators or combatants?
I suppose I can
Maybe.
start.
Yeah.
On the point about military necessity, one of the achievements of the Geneva Conventions going back to 1864, when they first began to protect healthcare in war, was to limit the use of military necessity as a justification for these attacks. And it limits them in a very specific way, that particularly military necessity can only be invoked as set out in the conventions themselves. There is no general rule that military necessity can remove protection. That's a very important restriction, and it also means that when combatants invoke it, they're not basing it, in most cases, on the law, because the use of military necessity is severely constrained. There has been, especially in the war in Gaza, claimed by Israel that the health facilities are misused. And here is a case where, according to the law, if a hospital is used for acts harmful to the enemy, it can become subject to attack. At the same time, there are very, very serious restrictions in such attack. The attack has to be limited. It can't be a general attack on the entire hospital, because there are rules of taking all feasible precautions and proportionality in attacks that say you have to protect the patients and staff in the hospital. Israel, to all evidence we've seen, has not done that. Secondly, there has to be evidence of current use, not that at some time in the past there was a tunnel. If that tunnel is not being used currently for military operations in the hospital, there's no justification for an attack. Third, there has to be a warning before an attack. That's different from a general warning under the law for civilians to be notified that an attack is coming. This is a warning that says, we think you are misusing the hospital for military purposes. You must stop. You cannot attack until you give some opportunity to cease the misuse. And only then can you attack. Those warnings are almost never given. There's no evidence that an opportunity is given for any kind of alleged misuse to stop. So even in the case where hospitals are alleged to be in some way being used to engage in combat operations, there's still serious protections. And what we've seen is that these rules are completely flouted. And there's also a media strategy that invokes misuse as a continual, almost daily justification for attacks, without making any attempt to assess the very strict limitations the law provides. I'll stop there.
Thanks, Len. And I think that was quite thorough. There's a bunch of questions about what next, which I will kind of mush together in a few minutes. But first, I'd like to highlight more of the data and the findings. Jira White from OHCHR says thank you, and then says, the report discusses how these attacks impact access to medicines, vaccines, and other health products. To what extent does the right to health framing influence SHCC's data collection methodology or reporting? Christina, I'm curious what you think about that.
Thanks for this really important question. So I think the right to health is kind of the basis from which we start with the idea that there has to be access to healthcare in conflict. But the much more detailed framing is then really around looking at the individual incidents that are carried out by conflict parties, that then directly impact the right to access to health, if that makes sense. So we're coming from the broader to the more narrow in the way we are then defining what is in the report.
Thanks, Christina.
Jump
And
into,
Gerald, oh,
if you
please,
don't
yeah.
mind. Yeah, no, I was just going to add to that there is a foundation of, that Len laid out in terms of international humanitarian law. But there's also clear impacts that go well beyond the direct attacks, right? And that includes, the long-term impacts of the destruction of health facilities. It includes the ways in which transportation to health facilities are impeded by conflict. That all impact the status of the right to health in different countries. Where there's occupation forces, they have specific obligations to ensure the right to health is upheld, and that's often not adequately carried out and addressed. So I think, speaking for the effort as a whole, I think we're looking at all of these things together, and trying to see how do we move this forward effectively, and what are the best mechanisms to explain the violations that occur from an IHL perspective, from a human rights law perspective as well.
Thanks, Joe. I really appreciate that. Robel, did you want to add something on military necessity?
Yes, certainly. Thank you so much, Rohini. Essentially, I think in the case of what's been happening in Ethiopia, there's been a problem with a monopolization of information by the state. So we mentioned, for example, the toll of drone strikes and other types of explosives, heavy artillery. And, for example, the head general of the National Defense Force, Field Marshal Burhanu Jula, had appeared on state media towards the end of 2023 and essentially denied that these attacks were targeting civilians at all. So he insisted that the attacks were exclusively being carried out against combatants, which was a flagrant lie. And this was, contradicted by our own reporting, as well as reporting from various other sources, even the UN Center for Human Rights at the time. And unfortunately, what the state has been able to do has been to crack down, for example, on independent reporting. So independent medias and journalists were essentially rounded up very early in the war and throughout to ensure that there was no organized, narrative to actually counter what the state was saying. And this was very harmful. And this is actually very relevant right now, because just this past weekend, there was actually a campaign by a coalition of independent Amhara medias drawing attention to, for example, some of the censorship they've been faced by tech giants like YouTube. So it's unclear what exactly is happening, whether it's maybe coordinated reporting campaigns, but many of these channels that were actually providing independent reporting have been shut down. They've experienced demonetization, they've experienced channel termination, and this has been very concerning, because in a lot of these conflict zones, for example, internet and communications can be shut off for very prolonged periods of time. And this has been a strategy employed by the Abiy regime. And so if there was access to that information through YouTube, through social media, that could actually be a lifeline to residents about what could be happening, things to expect with the developments in the war. But when that's shut off, and when these medias are deleted, essentially there's this communication blackout, and then it allows the state narrative to dominate. So this has been a very important trend. And then just very quickly, there's also been a lack of reporting from international media. So not only do they have this state dominance domestically, but even abroad, because of that lack of international media coverage, there's a tendency to assume, oh, like nothing's happening there, or it's just some kind of minor conflict that doesn't deserve attention. And I think these are very important themes to highlight, because this is the difference between starting to get towards solutions. It starts with acknowledgement of the problem. It starts with acknowledgement that there's a major war going on and it's impacting a lot of people. So just wanted to add that in. Thank you.
Thank you. Jira White and Srihari Acharya are asking questions around disaggregating data. Specifically, we know that folks like community health workers, women, other types of health workers, potentially patients, also could face different vulnerabilities. And Christina, does Insecurity Insight disaggregate data at all like that? And so, or like, what do you see on that in terms of trends?
Thanks. This is a really important question. So I think we need to distinguish in a way between the aggregation on the direct impact during an attack, and then the impact that is long-term that results from the destruction and the weakening of the health system. And in terms of the direct impact from an attack, we do disaggregate as much as we can, but based on what is reported, and what is not reported, we can't disaggregate. But I think what your question really refers to is how we can better articulate what the impact of the weakening of the health system are for the people who most depend on health systems, because unlike food that everyone needs every day, the health system is for people with particular vulnerabilities, or then also pregnant women or young children, for example. And I think in that respect, the question is so important, and how can we better document how the long-term impacts, as Joe also sort of mentioned, can be, the narrative can be built, and that goes far beyond the one day where a destruction of a health system item occurred.
Thanks, Christina. I'll also add that this webinar is being hosted by HCRI at the University of Manchester, which is also leading an initiative called the Researching Impacts of Attacks on Health consortium. And as part of that, we've been thinking about especially women health workers and community health workers a lot more. We wrote a paper on women health workers, and especially rural women health workers in Colombia, and the sort of intersectional vulnerabilities that they face, and how hard it is for them to leave those communities as women and family leaders. So I put that in the answered questions area as well, and happy to talk about that more. I think it's about time we jump to what next and where we're going to go from here. And there's a number of questions on that, which I'll just touch on a few and then maybe let everyone sort of start talking about. Camilo Valderrama asks and mentioned that next May is going to be the 10th anniversary of UN Resolution 2286, which was the first UN Security Council resolution that asks or demands member states to ensure that there's protection of health in conflict settings. What's the advocacy strategy around that? And he specifically asked, I'm a medical doctor and practitioner. What are the concrete actions to ensure we can bring this to court? In addition, Danny Poole asks, what are the challenges that have to date prevented the prosecution of attacks on health? Is that an option in the future? And then I would also add, are there legal, financial, or advocacy strategies that you see as being sort of the next step, either in specific contexts or more generally? Joe, maybe I'll start with you on this.
These are tough questions. I mean, there's definitely a need and the ability to try and see specific, cases to be heard against forces that are engaging in attacks on health. That should have been done by now. It should be something that people are willing to get behind. It's not going to end the problem everywhere, and it's not going to be a quick process either. But it's one of the strategies that has to be engaged more directly. I think there's also, a reasonable hope that there can be global leaders emerging and championing this from all different regions of the world to try and clarify and make sure everyone understands what the obligations of the Geneva Conventions are. I would flag also Les Roberts' comment that, is the term attacks on health an adequate term to represent all of the impacts on this? Is it a clear term? Is it a powerful enough term? Is it a term that we've been using for a long time and hasn't been working? And that speaks to like a broader advocacy need we have, which is to try and, get people to understand that these are, unlawful, illegitimate actions, and, that can't stand, basically. And so I think that really, from my view, all of these advocacy approaches are things that, especially in this year, the 10th anniversary of 2286, we really need to be discussing, engaging, and building stronger partnerships and exploring.
Tammy and Robel, do you have thoughts on this from your specific expertise? What next?
If Tammy, would you like to go
go for
first?
it.
Should I? Okay. I think in terms of what next, the way I see it, there needs to be, at least in the case of Ethiopia, an end. We need to see an end to the cycle of impunity. We're seeing consecutive wars with emerging patterns of the same types of wrongdoing and the same types of abuses. And I think to an extent, there might be some extent of empathy drain among observers as well, among international observers. But it's important to understand that these things are actively happening, and also ignoring them is not the right approach. And so there needs to be a continued push for cessation of hostilities, restoration of peace, and a transition towards reconciliation, rehabilitation, and healing for all. But this needs to be an inclusive process that doesn't leave out different stakeholders who have played central roles in what's been going on. And earlier in my presentation, I mentioned, for example, a peace deal that was signed in November 2022, which ended fighting in one region, but failed to stop fighting in other parts of the country. And so I think that was a lesson in what not to do when you have an exclusionary, non-transparent process that is focused on maybe a short-term type of gain, a diplomatic gain. I think what we need is a genuine approach that considers all stakeholders, people on the ground. And I think if we can accomplish that, and if we can, support that kind of a process, we can see a much more favorable outcome. And so that would be my recommendation.
There's a set of questions now. Zahir Salul asks about Syria. The main reason for the increase on attacks on healthcare is the lack of accountability. Syria was an inflicting point. So far, there's no perpetrator who attacked a hospital who was brought to the court of law. Why not pursue such accountability through the ICC, the ICJ, or universal jurisdiction? Sort of echoing Daniel Poole's question as well. Len, can I ask you this question? Is there avenues that you think are even possible in this political context right now?
This is absolutely the right question. We have mechanisms that are available. We have the International Criminal Court. We have principles of universal jurisdiction. There are always obstacles to prosecutions. For example, you have to get custody of the perpetrator to bring the case. But we've seen that happen through prosecutions by the International Criminal Court and universal jurisdiction. It's a matter of making it a priority among prosecutors in these courts, whether they're international courts or domestic courts that can bring cases. And they have, in some cases, in many cases, in fact, brought cases around sexual violence or other crimes against humanity. But they haven't, they're like others who respond to demands for kinds of cases that are prosecuted and how they set priorities. And I think what's been missing is the kinds of demands for accountability through prosecutions that they have jurisdiction to pursue. And I think that's where we need action. We need action among our colleagues, among professional organizations, and also among UN agencies and member states. And that is where the roadblock has been. It's not a matter of a legal obstacle other than getting a hold of the perpetrator. It's a matter of willingness to investigate properly and bring the cases. The cases can be complicated, like all international crime cases, but that's not the main problem here at all. It's the lack of priority given to these cases. And that's where we have to act all together.
Thanks,
Rohini,
Len.
sorry,
Yeah.
jumping on to Len's point, he had indicated that, medical societies and organizations domestically and internationally can also help in kind of bringing pressure to international courts. I want to point out that medical societies and humanitarian societies and organizations and all of that also have roles to play domestically as well. We saw this work to a large extent in Turkey, where medical professional societies advocated for their colleagues who had been imprisoned at one point or politically censored. And we saw that kind of launching this trend of medical societies not only becoming active in the political sphere in their domestic sphere, but also that having reverberations on an international level. So I think, it would be a mistake to kind of wait for retrospective justice in this space, and the activation and the visibility and the solidarity of these societies and organizations is really going to be critical moving forward in making sure that there is accountability for these attacks.
Oh, you make such a good point, Tammy. In the interest of time, I wonder if I can wrap it up and ask each of you this last question, which is, what is your top line recommendation for what we can do now? This can be for individuals listening in, for organizations, even the perpetrators. But what would you want people to take away from this after looking at how severe this problem of attacks on health is, attacks on or interference with, as we used to say before? Or yeah, what would you say is next? And Christina, maybe I'll start with you.
Thanks. I think my wish would be for everyone to think of the area they work in and who their stakeholders are, who they can talk to, and to think what any particular group can do. Because I think we have to look at it from a multiple perspective. We can't put it on the shoulders of the health workers to solve this issue. We have to think more broadly of what so many different people within society can do. So that will be my wish for everyone to think, what is the particular role the people I am engaging with can do to improve the situation here?
And Tammy?
Yeah, echoing that. I think people who are involved and engaged in this space tend to think of this as a very obvious problem, and one that is, it's complicated but obvious. And I think sort of the challenge moving forward is using this moment in particular and using this data in particular to drive the seriousness and to kind of use it to forewarn of potential future repercussions that we will face if we continue to either be complicit in attacks on healthcare or be silent on it, or allow our solidarity in any way to waver. So I think really using this moment and using this data to galvanize actions moving forward as kind of an inflection point of it's now or never, right? It's quite literally do or die at this point.
Ravel?
Certainly, I too echo what my colleagues on the panel have said, and I think for me, I see it as something where we can work to strengthen civil society, independent media, all of these other stakeholders, which can be a voice. I want to recall an incident related to the ongoing health workers civil movement that's going on in Ethiopia, in which a doctor was arrested following an appearance on an international media outlet. I believe it was BBC. This was Dr. Mali Gush, and she appeared to discuss what the demands of the health workers were. And this was a movement where they were at odds with the state, demanding certain responses to long-held grievances. And she was arrested soon after. And so this, I think, illustrates that these health workers are vulnerable and sometimes unable to advocate for what they need, even in opportunities where they speak out. And so there needs to be a strengthening of other voices that can support them and that can talk about the issues. And it starts with, I think, platforms like these, which are highlighting some of these important issues, which I want to thank all of the organizers for. So I think it starts with just recognizing, acknowledging the problem and raising awareness. I think that is very powerful. Thank you.
And Len?
I agree with what's been said. I would add that we need to focus on who can make a difference. We need to mobilize, and who should the pressure be on? And I think it has to be on the governments over which we might have some impact. They need to hear this demand. They need to feel the pressure. And additionally, we haven't talked about this today, but it's a huge issue. It's not just that governments are not taking action to stop these attacks. They're actually fueling these attacks by their continued sales and transfers of arms to perpetrators, all prohibited in many respects by international treaties and domestic law. So we have to hold them to account as well, to stop fueling these conflicts with arms sales, stop fueling attacks on healthcare by these arms sales. And that's where the pressure has to be placed so that they act in a way that defends humanity, stands for humanity, and stops this terrible violence.
And Joe?
With what everyone has come before me and what they've said, but picking up on Len's comment about global leadership, we've seen that change can happen in terms of landmine conventions, in terms of attacks on education campaigns, and we need to have more momentum towards the goal that we're seeking. We need to have better allies to help push into the spaces that we need to be in to get a real game change here. I mean, this is something that when you educate people, they recognize that it's wrong, but they come up with excuses, and we need to have enough of a strong voice back saying that no, there are no excuses here for these kinds of attacks.
Thank you, Joe. And I'll just take my moderator's privilege to add that one thing that I see is that there's colleagues here from all over the world. I see folks who work in, well, at least names from Turkey and Colombia and Ethiopia and Gaza and Syria and Haiti. And I think one thing I'd like to see in the next year is to break down some of the silos between the regions where there's so many attacks on healthcare, and really have conversations across these places, not just with those of us in the US or Switzerland, but really between these places, and see how health workers can connect both within their own organizations and across these organizations. And I'd really also like to see some of the momentum building around continued funding of these resources, and especially, with the lack of USAID leadership on this and others, I think this is a big issue as well. There's always more research to be done and more studies, and more reports to be written, but I'm hoping this translates more and more into action. I want to thank everyone for spending this hour and a half with us. And I'd like to say, you were able to access this webinar. Please join the listservs for both Insecurity Insight and SHCC if you can. And you can always email us directly as well through that. And we'd love to keep this conversation going, especially as Camillo said, and we followed up with the 10th anniversary of 2286 happening really soon, in less than a year from now. I think this is going to be a real moment to push forward on this issue. So thank you, everyone, and have a good evening or morning or afternoon. Take care.